Hello friends, welcome back to my channel in the new video. This is a part 5 and the concluding final video on sedation, analgesia and NMBs. And we have extensively covered the sedation and analgesia part along with the delirium in the last four videos. And this is a fifth video which we are dealing with neuromuscular blocking agents in ICU. So let's start. So, when we talk about rapid sequence intubation, especially in the ED or even in ICU, you may have options of non-depolarizing agents and the depolarizing agents. And as we know that there's one single important depolarizing agent in the form of succinylcholine, and the non-depolarizing agents either in the form of atracurium, mivacurium, uh, and rocuronium and vicuronium. So these are the agents which we should be aware of, and as we know that uh, their mechanism of action and their profile, they go hand in hand, but there are few differences which we will see, and they are usually synergistic with each other, uh, as we know. So talking about succinylcholine, it's a rapid action, rapidly active agent which is used for rapid sequence intubation. The duration of action is between 6 to 10 minutes, and with the dose of 1.5 milligrams per kg per IV bolus. And we need to be little careful in patients with myasthenia, as we know. And so these are the absolute contraindication as far as the succinylcholine is concerned. The patients with malignant hyperthermia, neuromuscular diseases, and as we are talking about myasthenia, actually it is a little safe in myasthenia, and that is why I had put it in the earlier slide. So barring all the other neuromuscular blocking agents, mind you, succinylcholine is a little safe in myasthenia, but definitely it is a cause of concern when the patient has muscular dystrophy or a stroke, rhabdomyolysis, burns, or a significant hyperkalemia, which is seen in the ECG, as a ECG changes. So rapid sequence intubation, when you talk about it, of course, the first agent which comes to our mind is rocuronium because it has a rapid onset of action. Uh, it is in the dose of 1.5 milligram per kg IV, and of course vecuronium, which has a delayed onset of action with a dose of 0.5 milligrams per kg, and pancuronium, which is not available in most of the hospitals and it is not used. So what I can actually conclude for RSI today is, I think you should remember rocuronium for its obvious benefits. And the another important factor why the rocuronium is preferred is because it has an antidote in the form of Sugamadex, and it is available in various hospitals. So of course, the rocuronium would be the drug of choice. And these are few of the indications for the use of NMBs in ICU. It will facilitate the mechanical ventilation in patients with severe hypoxemia, in patients of ARDS or any other things. It can cause shivering due to therapeutic hypothermia following cardiac arrest, and the emergency intubations or to facilitate treatment of medical conditions like neuroleptic malignant syndromes or status asthmaticus, to facilitate short procedures under general anesthesia. Sometimes when you use it for endotracheal intubation, as we are discussing about RSIs, to prevent unwanted motor movement in respiratory distress, and patients who are coughing, dysynchrony, asynchrony. So these are the indications when predicted. The conventional strategy of sedation and analgesias which have failed, and then you go to the NMBs in these particular situations. So in ICU, when you talk about ICU, we have agents in the form of vicuronium, atracurium, or cisatracurium, and by and large, atracurium and cisatracurium are preferred because of obvious benefits that we will discuss shortly. That these patients who have liver failure, renal failure, those who are elderly, they tolerate this well, especially in sepsis, septic shock, electrolyte imbalance, and the obesity patient. All of them tend to actually tolerate atracurium and cisatracurium pretty well. Vecuronium, yes, but then it will be probably a little low on the list. And again, to revise that RSI, when we are discussing RSI, we are probably talking about rocuronium. When we're talking about NBM in ICU as an infusion, we are talking more about atracurium and cisatracuriums and less of vecuronium. So these are the clinical interactions with the NMBs, and these are the inhibiting agents or the inhibiting conditions on the right side like alkalosis, electrolyte abnormalities like hypercalcemias, demyelinating lesions, peripheral neuropathies, diabetes, massive trauma and burns. And of course, these are the potentiating conditions where they can potentiate the actions of NMBs like acidosis, the various electrolyte abnormalities like hypokalemia, hypocalcemia, hyponatremia, neuromuscular diseases like myasthenias, polios, Eaton-Lambert syndrome, multiple sclerosis, acute intermittent porphyrias, and the renal and hepatic failures. So NMBs in ICU, as we know that they will actually, why are we worried about them is because of the propensity of them to cause the diaphragmatic weakness, and which will in turn cause atelectasis and of course more and more ICU acquired weaknesses. So you give a bolus of rocuronium maybe, and then followed by infusion of cisatracurium or an atracurium only when in few situations. Personally, I don't believe in the infusions of the neuromuscular blocking agents. I will top them up. I will ensure optimum sedation and analgesia infusions, and with, of course, regular clinical assessment whether the patient is triggering or shivering. And you need to have the monitoring of these particular agents in the form of peripheral nervous system or the trail of 4 to know the intensity of the neuromuscular blocking agents, and of course the oscillometers which are available, and of course the tapering which is not required. So unlike sedatives, you don't taper these agents, you just stop them. But as I said, I will personally not prefer a infusion of cisatracurium or atracurium. I'll probably give them the boluses as and when required after the optimum sedation and analgesia. So these are few of the side effects. As far as vecuronium is concerned, it can have a vagal blockade with large dosages. You have very less side effects with rocuronium. Pancuronium we don't discuss because we don't use or we hardly use it. Atracurium, yes, there is histamine release, so there could be some hypersensitivity in few of the patients. In succinylcholine, of course, you may have myalgias or bradycardias or even asystole in children with repeated doses. And but mind you, that is the one which we have discussed is a little safe in myasthenia. So this was NEGM paper which talked about NMBs in early ARDS patient way back in 2010. And as you could see, that the probability of survival in patients with cis atracurium, especially in the initial 48 hours as compared to the placebo. And so this was a paper where they talked about cis atracurium group which had a significantly more ventilator free days, and the same group with more days free of organ failures or other than lungs during the first 28 days. And this was very clear that probably this is the time when we should start thinking of cisatracurium infusions, especially in ARDS patients. And this was a critical care paper which was published in 2013, which talked about neuromuscular blocking agents in ARDS, which was a systematic review and meta-analysis of randomized controlled trials. And the message was it will reduce the 28-day mortality, it reduces the barotrauma, and of course it has no significant risk of ICU acquired weakness. So when you use it for a shorter duration with the agent which is preferred over others like cisatracurium, we may have a chance that they will also have a less chance of ICU acquired weakness. So these are few of the strategies for managing pain, agitation and delirium to improve ICU outcomes. As we know, so this is probably summarizing the things what we saw is the daily sedation interruption policies, that is we call it as lightning, and that has a grade 1B evidence. Analgesia first sedation with a gradation of 2B. Early mobilization which will decrease the delirium and of course increase the chances of survival for these patients. Protect the sleep cycle, improve the sleep hygiene, and we are looking at a patient, the pain-free comfort and not the painful coma. And probably this is my last slide, which talks about that we saw that the first era was of paralysis, the second era was of the coma, and the third era is what we are in, and we talk about giving patients what they need, the pain free comfort using minimal sedation. And that's all for now. And this completes our sedation analgesia and NMB uh, talk, spaced into 5 videos. I'm sure that you must have enjoyed it. I hope it has have had some value additions in your existing knowledge. And that's all for now. Take care. Tata. Bye bye.